Okay, thanks, Prof. Good afternoon to everyone. Our topic today is substance use disorders with myself, Nkosi Nati Ndala, otherwise known as Nati, as well as Mankosi Padi. So this is the quick overview of what we'll be talking about today. And in terms of the introduction, basically substance use disorders fall under the substance-related and addictive disorders in the Diagnostic and Statistical Manual, Volume 5 of Mental Disorders. And it's defined as a cluster of cognitive and behavioral, and physiological symptoms related to a substance that is used by an individual in such a way that they continue the use of that substance despite any biopsychosocial related problems. And I'd like us to think of the substance in this context as the chemical composition or drug that is capable of producing this psychosocial and physiological changes to an individual that uses the substance. So before we go on, I'd like us to go through a couple of definitions. In particular, the differentiation between substance use and substance abuse, where substance use is just the usage of a particular drug or chemical that induces certain effects to the patient. And typically, in the case of a substance use disorder, this physiological and psychological or behavioral changes are actually expected and sought by the patient in topic. Whereas in the case of substance abuse, this is when the substance use becomes maladaptive to the patient's life and poses a very serious risk to the patient's life or well-being. Now, we also need to bear in mind that there is a concept of substance intoxication, which is basically a set of symptoms that the patient experiences and for most of the time is expected, that are also consequential of the use of that particular substance. A concept of substance tolerance is when the patient starts then, due to continual use, getting a level of adaptation to a specific drug, and which then prompts the patient to start seeking higher doses of that drug in order to get the same desired effect. And then following would be substance withdrawal, which is a physiological, psychological, or behavioral change that is resultant of the cessation of the substance use, and it's usually following prolonged use of the substance that is also heavy as well. And lastly, we'll speak on the substance dependence, which is a maladaptive change in behavior resulting from substance tolerance and withdrawal, in which case the patient perceives the need to continue using the substance in order to avoid withdrawal. And this becomes a feedback loop where where the patient starts getting tolerant to the substance, therefore needing more of the substance. And when they try to stop using, they then get withdrawal symptoms. So this particular term is defined or characterized by monopolization of thoughts, loss of control, as well as social changes. So basically, this is an image that we got from the University of California, a lecture on substance use and theories of substance use disorders. It basically shows a circuit for reward that is normally there to allow the patient to focus on reward as well as activities that are beneficial for the patient. So, for example, food, they mostly appetitive processes or activities. So things like food, things like sexual intercourse, and so forth. So the way that the circuit works, it's primarily a dopaminergic circuit where dopamine is produced from the substantia nigra, the pulse compactor of the substantia nigra, as well as the ventral tegmental area, and moves towards the nucleus accumbens, where it's thought that that is where desire as well as the reward is manifested. Then from that area, it is then sent to a couple of other key areas of the limbic system or this circuit. The first area that I'll talk about is the hippocampus, where so hippocampus basically is where short-term memory is stored, as well as it plays a key role in learning. So the idea is that the now activated nucleus accumbens sends some information to the hippocampus, where you start recalling your experience and saving it as a newly learned process. And then furthermore, the nucleus accumbens will send information to the cingulate gyrus, more specifically the anterior portion of the cingulate gyrus, which has a multiple number of functions, and it sort of plays as an area of confluence for the prefrontal cortex as well as the rest of the limbic system. But in this particular context, it then works as where we generate that, or sort of we're able to perceive that desire that has been formed in the nucleus accumbens, and it's also supposed to work as an area of impulse control together with the prefrontal cortex. So when the perceived stimuli activates the cingulate gyrus, it then creates an emotional response to that particular substance. So you could think of it as looking at a piece of cake that you like. As soon as it reaches the cingulate gyrus, you form those fond memories that you have as you're eating the cake. Or if you're not eating the cake, it's sort of an area of confluence for you to remember those sensations together with the hippocampus. Now, the other important part is the prefrontal cortex, more specifically the orbitofrontal cortex with the dorsolateral prefrontal cortex. This is where planning as well as impulse control is mediated. So the issue with substance use is that it's been shown that when you overstimulate this circuit, which is the case with many substances, that you cause a disconnect between the nucleus accumbens with the prefrontal cortex, which means patients that are substance users eventually lose the ability to control their impulses and plan forward beyond that. So what they've seen is that there's debulking of the gray matter of the prefrontal cortex, and it's not because cells are dying.
Nati, can I just warn you about time? And if you can just, just be aware of time.
Okay, so in essence, basically, that disconnect between the nucleus accumbens and the prefrontal cortex stops the patient from being able to control their impulses, and further precipitates the seeking behavior that we see. So the next slide actually shows an experiment that was carried out that shows that the relationship between stimuli and the activity of the nucleus accumbens in terms of dopamine. So we see that when we add food or things like sexual intercourse, there's only about a twofold increase in the activity. But when you add something like methamphetamines or cocaine or nicotine, as well as morphine, it can go up to 10 times. So that increase in the activity of the nucleus accumbens actually is what eventually causes that disconnect. And it then puts the patient into a feedback loop where they cannot stop themselves from craving the drug, but also because this is a learning process, also focuses the patient on that particular activity, which is the seeking of the drug. So in terms of epidemiology, what we found that it's a bit difficult to find proper statistics in terms of substance use. And the reason why is because most of the statistics is gotten from patients that have been diagnosed and admitted for further management. So there are some drugs, for example, nicotine and caffeine, which culturally do not really give you any adverse effects that would require the patient to seek out any rehabilitative management. So the only ones that we can see are the ones that actually disrupt the patient's social standings and so forth. And so they are usually brought in by family or by other co-workers or other members of the community. So by and large, alcohol is the most prevalent of all the drugs that we've seen at 51%, followed by stimulants as well as opiates. We in South Africa, fortunately, are not, in terms of the admissions, we are not really seeing high numbers of patients that are there for rehabilitation for over-the-counter drugs. And then it's also very difficult because of the other types of drugs, such as inhalants, since they are very easily accessible. They are mostly products that you can get from supermarkets, such as glue and other like thinner substances. And then there are other concoctions such as nyaupe, for example, which is, it tends to be a mixture of a lot of drugs. So it becomes very difficult to be able to get the epidemiology based on those things. Now, there are some risk factors that sort of worsen the chances of a person getting a disorder, a substance use disorder. Most notably are cultural attitudes, like we've spoken in terms of nicotine and caffeine, where the society does not deem them as harshly or does not stigmatize against them, and yet they are very addictive substances. Also, socioeconomic statuses in terms of environmental, where it's been seen that places that have very little substance-free enjoyable activities, such as soccer clubs, chess, and those things, actually show a higher degree of substance use disorders, particularly the alcohol use disorders. Peer substance use, as well as substance use in the household, actually shows that the patient shows a low or perceives it as low risk to themselves, since peers as well as family members are using it. And also the high perception of reward and normalcy when the peers themselves actually look like, for example, they're having fun, actually is one of the reasons why they would start using substances. This is particularly important in adolescence, where peer pressure is rife. In terms of the drug availability and cost, this is also one of the risk factors, where, and particularly with the concoctions as well as other drugs like heroin, where the price of the drug, as well as the effects that it has, particularly when the patient is starting to gain tolerance, they start moving towards these cheaper drugs, which are more addictive and more hazardous to their health. And then lastly, adverse child experiences such as abuse, physical abuse, emotional and sexual abuse actually is a risk factor. Mental illness and also early onset of use are some of the risk factors that were noted. in terms of protective factors, adult role models, and parental discussions of the risks involved with substance use, particularly with the youth, actually lowers the risk of substance use, as well as, like we said, the substance-free enjoyable activities. And then there's that sense of connectedness at home and school, as well as the community. So being involved in community projects, being involved in household discussions and at school is actually a protective factor. Now, there are a couple of screening tools with substance use. I've only placed the 2 here because particularly I think one part of the risk factors is early onset, which means if we can diagnose children at risk, we might reduce the numbers of substance users in adulthood. And so I've placed CRAFT. This is called the CRAFT screening tool. And because of time, I won't go through all of it, but it's basically, have you ever ridden in a car with someone who's under the influence, which includes the patient being asked, and then in terms of relaxation, whether they need a drug or alcohol, and so forth. I'm sure we can go through this at a later stage. And then points are as such: if there's more than 1 point or more than 1 yes to any of those questions, then we take it as a positive screen, and then we can start psychosocial treatment from that point. The other particularly useful screening tool is the CAGE questionnaire. Again, to reduce the time, I won't go through this, but I believe we all know this. We're all familiar with the screening tool. So in terms of diagnosis, we use the 11 question, and for myself, I find it very difficult to remember it, but I've tried to come across something. I came across a mnemonic that is easier. So the risk to bodily harm, it's basically the 4 R's and the 4 C's. So risk to bodily harm, relationship trouble, role failure in the family, as well as repeated attempts to cut back, and a loss of control, continued use despite harm, compulsion, as well as craving. And if the patient experiences any withdrawal, so you can ask whether or not they feel the need to take any of the substances to avoid certain unpleasant feelings, and tolerance, whether or not they've actually needed to increase the amount of the substance that they take. And the criteria for this is basically if they answer any 2 to 3 of these questions positively, then they have a mild substance abuse problem. If it's 4 to 5, then it's moderate. And if it's greater than 6, then it's severe. So in terms of the clinical presentation, generally we would look at these spheres of the patient. In general, you'd have weight loss and basically blood sclera or injected conjunctiva, as well as pinpoint pupils and track marks in the case of IV use, drug use. So some of these drugs share a lot of these clinical signs. So, for example, trauma can be because of any of the drugs. Viral hepatitis, though, is specific to IV drug use, but it can also be secondary to the behavioral and changes that the patients might have in terms of promiscuity. We've highlighted behavioral changes in terms of missed appointments and non-compliance, as well as drug seeking, which is essentially when you come across a patient in the clinic that has come multiple times seeking the same drug. Yeah. And then in terms of psychological changes, they have insomnia, fatigue, depression, and a flat affect. as well as some psychotic features such as paranoia and hallucinations and delusions. In terms of social issues, they would have social discourse, family violence, and also absenteeism and low performance at school or at work. And then now we've divided the drugs into 3 categories. So those would be depressants, stimulants, as well as psychedelics or hallucinogens. And then we've tried to focus more on, or to highlight, the drugs that are higher, that are of higher prevalence in our communities. In this case, will be alcohol and opiates under the depressants, but also barbiturates as well as benzos. And the intoxication process or clinical features in terms of intoxication would be euphoria, slurred speech, disinhibition, confusion, poor coordination, as well as coma. And if severe, it could even lead to death. So these are some of the things that you should bear in mind in an acute setting, because depending on which category the substances fall under, their management could potentially be different. There are some withdrawal symptoms that have been noted by the DSM-5. In terms of depressants, they would have anxiety, anhedonia, tremors, seizures, insomnia, psychosis, and delirium. And in particular to most of them, in particular with alcohol use, they might even result in death, as well as other more chronic complications such as Wernicke-Korsakoff syndrome. Yeah. So alcohol withdrawal. So I just mentioned this one because it's the largest or the most prevalent of all of the substances used. So this one occurs within a period of 12 to 48 hours after the cessation of the use of alcohol, and it may be life-threatening. So you divide it into 4 stages. 12 to 18 hours, that's where the more lighter symptoms occur. So tremor, sweating, agitation, and anorexia, cramps and diarrhea, and also sleeping disturbances. When it starts becoming more serious would be within that period, but towards 48 hours, where you can expect alcohol withdrawal seizures, as well as starting to have psychotic features. Most of the time that would be greater than 48 hours. So hallucinations would be the hallmark of that. And then stage 4 is when you start having more serious symptoms such as delirium tremens, as well as autonomic dysregulation with psychosis and agitation. So there is a concern for the elderly, where in the elderly, withdrawals are actually a bit more severe. And when they have things such as delirium tremens and more severe withdrawal symptoms, they are more likely to not resolve completely. Whereas with the younger people, their symptoms can most of the time be resolved or be reversed completely. Unless we talk of the Wernicke-Korsakoff syndrome, which is basically a thiamine deficiency. And the reason why I put this one here in particular is that every single patient where you suspect that they might be intoxicated, and in particular they're intoxicated by alcohol, if you want, when you start giving when you start giving fluids, all fluids must contain thiamine, because you might precipitate the Wernicke-Korsakoff syndrome. All right. So going on into stimulants. Stimulants are basically The ones that we put in here are amphetamines as well as cocaine, and they give you euphoria, mania, psychomotor agitation, as well as anxiety and so forth. And in particular, you should consider the cardiovascular complications such as myocardial infarction, strokes, and arrhythmias. And they could also give seizures. The withdrawal has been, according to the DSM-5, as a crash where the patient basically goes from a high, which is the mania and the euphoria, and they just crash to extreme lows where they anhedonic and they lethargic and so forth. There's also withdrawal has been placed as craving and dysphoria, as well as in particular suicidality. Hallucinogens, in those cases, we noted LSD and ketamine, as well as mushrooms, which is the psilocybin. Their intoxication is distortion of sensory stimuli, as well as enhancement of feelings. Psychosis, delirium, anxiety, and poor coordination have also been placed. So these are usually party drugs. So they usually don't have any dependence. And because they don't have any dependence, they don't have any withdrawal symptoms. So patients that use these drugs normally use them in parties or when they are going out. So they tend to not have any dependence. So that will be myself from the first part. Dr. Mankos will take over for the treatment.
Hello, everybody. I'm Mankosi. My main focus for today is the treatment of substance abuse. The treatment approach is to look at 3 levels of prevention. Number 1, primary prevention. So as primary healthcare workers, we must prevent the initiation of substance misuse through educational campaign, like, for example, if you are in your consulting room, you must make time to teach patient about substance abuse. You must have posters in your consulting room. We must go to schools and target the teenagers. The other thing is community and family intervention. As Nati has mentioned that for some other people it's a norm. So we must target those people and teach them about substance abuse. Number 3 is carefully prescribing our medication, especially our benzos, because most people tend to be addicted. The other thing is policing of illegal drug trafficking. The cost, we must take into account the cost. If drugs are cheaper, people tend to have access to drugs. If drugs are, and again, making drugs illegal. So, and secondary prevention, this is when we already have a problem. What is important here is early detection and effective treatment to prevent harm from substance abuse. I'll explain that later on with each substance. Tertiary prevention, limit harm from substance dependency by effective rehabilitation. This is more specialized care. It can be in or outpatient care, detoxification, using some medication for some specific substances, psychosocial rehabilitation. This is more important because patients tend to connect with other patients and they can relate. Alcohol. Regarding alcohol, primary prevention is the same as I've mentioned above, and secondary prevention, as I've said, that this is where we already have a problem. For example, if you are in ED and you suspect the patient may be intoxicated, the first thing to do is your ABCs, your ATLS principle. As Nati has beautifully mentioned that alcohol is a depressant, so we need to make sure the patient is not depressed, neurologically depressed. While you're putting that IV line, make sure you give the patient thiamine as alcohol withdrawal regimen. Make sure you replace alcohol with long-acting benzos, with long-acting benzodiazepine, then gradually withdraw. Example, if you give diazepam 5 to 10 milligrams, 3 to 4 times daily, withdraw over 5 to 7 days. And don't forget vitamin B complex. Uncomplicated patient can be done as outpatient, but suspected complication should be managed in hospitals. Those with history of withdrawal deliriums should be managed in hospital. Those with previous convulsions, severe liver pathology, those that are physically severely compromised patient, and severe withdrawal symptoms. Regarding tertiary prevention, ensure that the patient enrolls. This is a long-term management. Ensure that the patient enrolls in a psychosocial rehabilitation programs and encourage them to attend after support groups such as AA to prevent relapse. Pharmacotherapy may also be used to psychosocial rehabilitation and prevent relapse. Disulfiram. Before we use, this is more advanced. Before we use this medication, we must get a consent from the patient. This medication, what it actually does, it inhibits the enzyme that breaks down alcohol, so patient gets severe toxic effects. So number 2, I'll talk about opioids. As Nati has mentioned, that heroin is more frequent. So these patients you usually see with needle marks. If suspecting that a patient might be using opioids, the management, primary prevention is the same. The management for overdose, we use naloxone. Naloxone 0.4 milligram IVI slowly at 2 to 3 minutes intervals. Max dose is 6 milligram. Tertiary is the same. It's just psychosocial rehabilitation. Management is long-term. Management in long-term is very complex and should be restricted to healthcare workers with experience in the field. We can use medications such as clonidine, but this is more for healthcare workers with experience. And 3 will be our stimulants. Primary is the same for all of them. Secondary, with stimulant, is just supportive care. If patients are restless, we give them benzos. If they are hallucinating, we can give them antipsychotics. Because patients who are using stimulants, they tend to have tachy and palpitations. As Natia's beautiful mentioned that we need to look at cardiac. So for tachy and palpitation, we can use beta blockers. Tertiary as psychosocial rehabilitation in the long term. And cannabis, this is incidental finding. Usually no management is required here. Withdrawal symptoms are not severe and detoxification is really necessary, but uncomfortable symptoms can be treated with reducing doses of diazepam. Number 4 is psychedelics. The last one will be psychedelics, your LSDs and others. The treatment is supportive management as they come, because most of the time they come hallucinating, just supportive management with our antipsychotics. And with tertiary, we just usually ensure that the patient enrolled in a psychosocial rehabilitation. This is our reference. Thank you, everybody.
Training, and it is not at colleges, it's largely universities that run that course. And
hi, everyone. Thank you very much. I shared some resources in the chat function, so thank you. I hope that's useful. Nati, thank you very much. I know we've taken a little extra time. People have fallen off. So let me close there. We'll take up the discussion next week in the case discussions. Please make sure I get all the slides and case discussions.